Hello everyone, welcome to part 3, that is acquired disorders in cardiac surgery. So let's start from this classification again. In the previous session, we have finished congenital anomalies. And in this section, we are going to discuss the acquired disorders commonly seen in cardiac surgery. The classification of acquired disorders is a little bit different from that of congenital anomalies. These diseases are generally classified due to the specific site. For example, valvular, coronary, and thoracic artery. First, let's start with the mitral stenosis. Mitral stenosis generally is the result of a rheumatic fever. Women are affected more often than men by a 2:1 or 3:1 ratio, nearly always acquired before the age of 20. And the patient becomes symptomatic 1 to 3 decades later. Interestingly, it is unknown why rheumatic fever leads to mitral stenosis in some and pure mitral regurgitation in others. This is the physiology of mitral stenosis. You see, due to mitral stenosis, the blood flow through the mitral orifice is blocked, and this will cause the pressure within the left atrium increased, and so is the size of left atrium. And then atrial fibrillation may occur, even blood cord formation within the left ventricle. It is called thrombus formation. That is a very dangerous situation. If this situation continues, the pressure within the pulmonary vein will increase. This in turn will cause pulmonary congestion. When the osmolarity is greater than 30 millimeter mercury, patient may have acute pulmonary edema. It is clinically seen as the paroxysmal nocturnal dyspnea. And the persistent spasm and thickening of the pulmonary arteriole will result in pulmonary hypertension. And this time, the right heart is overloaded, and so is the right heart size will be increased. So the final result will be right heart failure. At this time, patient may have peripheral edema, hepatomegaly, or even ascites. The large green arrow shows that mitral stenosis directly reduces the preload within the left ventricle. So the cardiac output will be decreased. And at this time, the physical tolerance for the patient will be lowered. The patient will feel fatigue and dyspnea. And this drawing shows these changes graphically. You see the narrow orifice will cause the enlargement of the left ventricle and even thrombus formation within the heart. And this time, pulmonary congestion or edema is common. And the elevated wedge pressure will cause pulmonary arterial constriction, and so is the pulmonary hypertension. At this time, the right heart is overloaded, and the size of right ventricle is increased. Patient may have tricuspid regurgitation. So the venous pressure will be elevated, and then liver enlargements, edema, even ascites will appear. And this picture shows the intraoperative view of a mitral valve. It's narrowed just like a fish mouth. And I have introduced this picture in part 1. It's called closed commissurotomy, invented by Dr. Bailey in 1948. During the operation, operator inserted one of his fingers into the left atrium through left atrial appendage with the help of a tourniquet. And then the dilator is inserted into a heart through the apex. So when the tip of the dilator is confirmed at the level of a mitral annulus, the dilator is fired. and then the stenotic mitral valve is opened. It looks simple, but the operation is risky because if hemorrhage occurs, the patient may die. In our hospital, the method was abandoned 15 years ago. With the advances in technology, another modified form of a commissurotomy called the balloon commissurotomy is being used now. And the operation is performed intermissively without surgical incision. Nowadays, the mainstream treatment for mitral stenosis is valve replacement. There are two kinds of artificial prosthesis. The upper one is called mechanical, and the lower one is biological. It's also called a tissue valve. And these two video chips shows how a valve is being repaired. You see, the upper video chip shows that the suture are passing through the prosthetic valve. After anchoring of all these sutures, the valve will be parachuted down to the native annulus of a mitral valve. This is a mitral valve replacement. So now the valve is being parachuted down to the mitral annulus. After the tying of all these sutures, the replacement is over. The second video chip shows the tissue valve replacement at aortic position.